Posterior urethral bulb, the second most commonest obstructive uropathy. In fact, the 1% of the etiology of obstructive uropathy, but it has higher rate of CKD progression. Almost it contributes 16% of the pediatric CKD. Incidence in general population is 1 to 5,000 to 8,000. Boys exclusively disease is in boys disease, and type 1 to 3, basically type 2 is non-obstructive, thereby it is not important clinically. How does it presents? Antenatal hydronephrosis is by far the severe sort of presentation. Even child can have your less oligo amniotic fluid, oligohydramnios, and even Potter sequence is possible. And in those cases, renal dysplasia is possible because of the severe sort of intrauterine presentation. Later presentation may be lower in tract symptoms like straining, poor stream, your fullness of bladder, recurrent episode of urinary tract infection, and AKI CKD. Bedwetting is common. Reflux nephropathy is possible, and your tubulopathy at one stage it can occur, leading to hyponatremia and hypokalemia, acidosis. There can be secondary vesico-ureteric junction obstruction, so renal damage here by chronic infection, reflux, bladder dysfunction, polyuria, urinary tract infection, and the RAS activation. To diagnose this disease, you need to do one good hand MCU. The and your at times you do not have answer, you might need to go for the cystoscopy and urethoscopy, that is endoscopy, and other secondary parameters, infection parameters, all this and that. To treatment of those cases, definite treatment is by fulguration, by at resection at fifth, seventh, and 12 o'clock position with a pediatric resectoscope at good hand and good center is essential. In the preterm, we have small resectoscope, preterm resectoscope, and term we have term resectoscope. So, and the reflux occurs in 70% of cases in unilateral, 30% cases it may be bilateral. So that decrease urosepsis needs treatment, and really the diversion and the alternative they are not the good choices. The ureterostomy, your vesicostomy, your nephrostomy, and catheter insertion, long-term indwelling catheter, you may not be able to enter into catheter into it because of the valve obstruction. And the other desperate surgery in intrauterine life is the reduct, basic amniotic shunt. Tried in the few centers in the West with some amount of success, but with some amount of technical difficulties also, and had some complications also. So diversion procedures like mitrophanol and all this and that, they are the alternative. They are not a good choice. The definite one is of course the fulguration, resection by resectoscope. Then outcome 50% may turn to CKD, SRD, 50% grow out of the problem.